Hey everyone, and welcome to the FLATLINING Podcast from Fulcrum Strategies. I'm Matthew Handley, and with me is our president and CEO, Ron Howrigon. Ron, hello. How are you, sir?
I am good. I hope you are as well.
I'm good. I don't know why we're doing the show today. There's clearly nothing in the world to talk about right now.
No.
It's just been a slow news week, a slow summer so far. Nothing exciting. I jest, of course, because our current president has stepped out of the presidential race. He said he's no longer going to be running for re-election. And as of the time we've recorded this, it looks like the vice president is going to be the presumptive nominee for the Democratic Party. So, Ron, I got two things I want to talk about today, but I want to start with this story because Kamala Harris was a candidate before in the 2020 election running against now President Joe Biden. She was one of the first people on that campaign stage to come out in support of Bernie Sanders' Medicare for All plan. And I want to look to, look into our crystal ball a little bit and see if we can glean based off of her past stances as running for president, based off her history as being a United States senator, what we might be able to expect healthcare-wise if she were to go on and win the general election in November. And I guess the first thing I want to ask is there any reason to believe that it would simply be a continuation of President Biden's healthcare policy, as limited as that may or may not be, of not enforcing the No Surprises Act, I guess sort of kind of advocating for a public option, as sort of a buy-in to Medicare for all? What do you think we could see? Do you think this will be a continuation of a Biden healthcare plan if Kamala Harris were to be elected president in November?
I think that's probably the most likely scenario. Now, not necessarily because, what would be President Harris is a staunch, firm believer of the Biden direction, but more because that's which way the winds are blowing. Mm-hmm. I've kind of, we hear a lot of people talking about politicians being flip-floppers. And I actually have sort of come up with a different sort of term for it, and I think about like sailboat racing. And when the wind changes a direction and they tack, which the boat heads in the other way to catch the wind that way, and then they tack over to catch the wind. And so I think politicians are very good at tacking. And if you look at Harris as candidate, she did that quite a bit. She came out in the beginning part being pro sort of Bernie Sanders. This when she was candidate in the primaries, Medicare for all. She realized that probably wasn't going to get her there, and she tacked away from it a little bit to get more left center. There's been items that she sort of tacked either way on. So, I think that it's not as much that she has some staunch, Bernie Sanders believes what he believes. Yeah. And if he were ever elected, he's going to, he'd run right into that brick wall. And in one way, I respect him for it. I agree with him, but I respect him for it. I think what Harris will do is much more of dependent on what happens in the congressional races. What kind of Senate and House she's looking at, what kind of mandate she thinks she would get in the general election, all of that stuff. And if that is, like we have now, more of a split, divided Congress and no heavy duty mandate, I think she'll sort of follow the Biden approach, which is a very sort of let's not take a hard, easily attacked position anywhere and be what I would call more left center than hard left like Bernie would be. Now, I think it's unlikely. Let's play out the scenario where she gets a massive Democrat win in the Senate and the House, and she wins, by a large percentage of electoral votes, and feels like A, she has a mandate, and B, she's got a strong majority in both the House and the Senate. Again, I don't think that's likely, but let's paint that scenario. And it'll explain what I mean by the tacking. Then I think candidate Harris, who has always been for universal coverage, while I don't think she goes all the way to Medicare for all, she probably goes very close to it, and gets much more aggressive on some sort of universal health care, maybe that includes our private insurance industry. And that could be the gov care, the public option. That could be, Medicare down to 55 buy-in. But I think that would be more dependent on what she's working with and what the election looks like than any sort of deep-seated philosophical belief, because she's more of a politician than really Bernie Sanders is.
Yeah, I would agree, especially with that last statement, more of a politician than Sanders. Sanders is reliably consistent about what he believes, and in many cases, I applaud him on that, because at least I know where he's going to stand on particular issues. Right. People that have longer memories or are, political and healthcare nerds like we are, they may recall that in 2020, Kamala's healthcare plan was called Kamala Care, and it had this kind of, the goal was to get to a sort of universal healthcare by the end of 10 years, but it was going to somehow include the commercial payers. It was going to somehow include commercial employer-based insurance, and it got a lot of criticism because it was not very specific. I don't know if we see that get resurrected at all if she's elected president in November. I do think it's important to note that she, as Attorney General of California, was signed an amicus brief, several amicus briefs for the Affordable Care Act when that was being attacked in court. But I think I agree with you. I think she's going to be a little bit more depending on which way the wind blows with Congress as whether or not they do anything in healthcare. I guess from a provider standpoint, do you think we can give up any hope of No Surprises Act being enforced properly if she's elected in November?
I don't see her election, if she's elected in November, being the driver behind the No Surprises Act being enforced, because it really doesn't do anything for her politically. Now, I think that the No Surprises Act being enforced is going to be much more dependent on other lawsuits, on Chevron, like we talked about, on other things. I don't think she's going to be the driver, as opposed to, I do think there's a decent chance if Trump wins that they enforce it, because it was a law that was passed under his administration, and it would be, a right tack away from what's been happening over the last several years. Yeah. But even like going back to the Kamala Care, to me, that's another perfect example of, I think she does have a belief that she would like to get you to universal coverage. But the politician in her, when you think about it, first of all, it wasn't very specific, so it was hard to attack. And 10 years is an interesting time frame for a potential individual who could serve 8 years as president.
Yeah.
Mm-hmm. It allows you to have your cake and eat it too. You can say, "Oh no, I passed universal coverage. No, I don't have to administer it.
Right.
It's not going to happen on my watch, but I passed it on my watch." It's a little bit not as dramatic, but a little bit what they did with the Affordable Care Act, where we're going to do 10 years of funding and 8 years of implementation. So that just to me again shows me that she's a more adept politician than a Bernie Sanders, who I think if he got in would day two would introduce Medicare for all and push for it.
Mm-hmm. I'm taking a look at a summary article here by MedPage Today on what some of her past healthcare proposals have been. They're predicting in here that she'll continue to defend the Biden administration's record on lowering healthcare costs. That's their language in here, not mine. Especially when it comes to capping insulin and stuff like that, which I think is a little bit interesting because the Biden administration takes a lot of credit for this. But if I recall correctly, we really started seeing the drug companies self-enforce this rule before it became a regulation. And of course, the Biden administration could probably say that they got them to start doing that, although I think the drug companies were acting more ahead of what the federal government was going to do. Do you think we'll see an expansion of things like with the Inflation Reduction Act, with the expansion of negotiating Medicare drugs? Do you think that'll continue under a Harris administration?
Well, I think she would like to. I think she would like to. She's talked about things like trying to cap drug prices on whatever the rate is they're sold in other countries, things like that. The problem she's going to have is she's going to fall squarely at odds with Chevron on that, because most of what that happens is not going to be through legislation, because you're going to have a hard time getting that through, especially if it's a divided Congress. That's going to be regulatory, edicts And Chevron takes a lot of the wind out of those sails. So, yeah, I think she'll try to do that. I mean, picking on big pharma is an easy target. And I'm not saying that they don't deserve some of it, but she'll have a harder time actually implementing it.
Right.
And again, it'll just be the nature of the beast on whatever Congress she inherits if she's elected.
Yeah, it'll be interesting to see what happens. Healthcare has taken such a backseat in this election. From the get-go, to be totally honest with you, it's taken a backseat. So I don't think we're going to hear much out of her other than, we need to keep promoting the Affordable Care Act and make healthcare affordable for all Americans, et cetera, et cetera. The kind of usual lip service you get to healthcare when there's not really a plan for healthcare. That's more of what I'm expecting, at least in the next couple of months. Unless something drastic happens and she decides that they feel that it's going to pull well, but it's just not something I think Americans care about right now.
Yeah, it clearly isn't in the top 10. Yeah. To be honest with you, if there's a second debate, and I know that's still up in the air, I wouldn't be surprised, but a second debate doesn't have a single question about healthcare. And if it does have a question, it'll be one and it'll be short.
I'm not even sure the first debate had a question about healthcare.
It didn't. Yeah, not that I know of. And so when you think about an issue that obviously we're close to, but that affects this much of our economy, that deals with so much stuff, and there probably won't be a single question in two debates if there is a second one, that tells you. And if there is, it will be abortion or Roe v. Wade rather than sort of healthcare at a cost level. So yeah. I think you're absolutely right. We're not going to see much about it in the election. And then what happens after the election is, given that I think the most likely scenario is some kind of divided Congress, either way, it's going to be very hard to get anything fundamental pushed through. And, another case in point about it not being top of mind, I still don't know if there is a Republican plan, and there really isn't much of one from the Democrats either. I mean, neither side has really taken it up, unlike other past elections.
Well, and the only thing we've heard from the Republicans is, well, we need to expand HSAs and tax credits for healthcare. And other than that, as we've discussed on this program before, that's clearly not the answer. I mean, HSAs are good, but most people that have them don't use them because Americans are not good at saving money. We've talked about that before. And so clearly that's not the answer, but it looks good to say that you have an idea, even if it doesn't work. So we will stay on top of this story. We will stay on top of what Harris, if she is the nominee, like I said, at the time of this recording, it looks like she's going to be the presumptive nominee. We'll stay on top of that and talk about it here on the Flatlining Podcast if anything changes. Ron, I want to switch gears and talk about a story that you were interviewed for that was published last week in New York Magazine. And the headline is, "In Denial, Insurance Companies Are in the Business of Saying No, How 4 Persistent Patients Got Their Money." You and our friend Wendell Potter were interviewed in this article. Tell me a little bit about what your discussion was with New York Magazine and what the message is that they're trying to get out with this article here.
Well, we're starting to see more. And I had another interview the other day that will come out in the future about this whole idea of auto denials, payer denials, AI denials, this idea that people are getting more attention to, that just because you have insurance doesn't mean that you're going to get what you need, or that if you do get it, it's going to be paid for, which I think is good that they're shedding light on this. And so that was really, part of the interview was, how does this stuff happen? And then another part of it was, and I love that they showed sort of the people who got it, is, well, how does the average consumer fight back? How do they make sure these claims get paid or they get the care that they need? So that's what I was happy to talk about, is here's how it happens. Here's what I think is wrong with it. And here's what you need to do to make sure that you don't just give up.
We've seen several lawsuits come forward against the payers for this issue. You mentioned in this article, you said it's a massive amount of money when you're looking at millions and millions of disputed claims. Do you think we're going to start seeing millions and millions of disputed claims? Is that a real possibility?
I don't think that's the answer, just because the average consumer is really not equipped to do it. It's confusing. It's intimidating. It takes time. It takes these appeal processes, if you're a consumer, are not easy. It's not like, hitting the reply button on one thing and it automatically, you
Mm-hmm.
know, sends an appeal. You've got to stand up for yourself. You got to understand what your rights are. You've got to have some help. So I don't think we're going to see millions and millions of appeals. And that creates a problem because as long as it's profitable to continue to do it, even if the payer loses, let's say the payer is losing 90% of the appeals. That's not the number, but let's say it is.
Yeah.
But only 10% of the people actually appeal. It still is financially viable to do it. That's the
Yep.
problem.
Mm-hmm. Yeah, absolutely right. And it's a story of volume here. Economies of scale. That's the phrase I was looking for here. This article talks a little bit about the No Surprises Act from the patient perspective. It seems that some of it's gotten better. However, of course, this falls more on the fault of the hospital or the billing company of the hospital. I am still seeing violations, even in my own life, of getting bills that were not sent to my insurance beforehand, either because they just didn't send it to my insurance or they're non-par and decided that they weren't going to follow the No Surprises Act. I've had both of those instances happen. And I'm wondering if we've talked a lot about the enforcement of the No Surprises Act on the payer side when it comes to IDR, when it comes to getting the QPA right. Are we seeing enforcement for the No Surprises Act on the hospital-based physicians that are non-par? And does that have a role in what gets denied automatically for a patient's insurance?
Yeah, well, one of the problems with the no strike, and there's a lot that's good about it. I mean, I've said several times, I love the fact that the patients get pulled out of the middle, because you're right. I mean, there are a lot of stories of people who go like, I was unconscious when I got to the hospital. I went to the ER, and where did all these bills come from, and why do I owe this money? So, no dispute there. But one of the problems with the No Surprises Act, first of all, is enforcement is still a question mark. When somebody's not playing by the rules, who enforces it? A lot of state Department of Insurance say, I don't enforce it. It's a federal law. It's not my law. CMS doesn't know how to enforce it. So we created something new that we've never had in this country, but we don't have a police officer. That's a problem. Now, hopefully that will get better over time. I will say that it seems to me there's more enforcement against the physician who bills inappropriately, because the payers will try to enforce that. They will push for it. The payers who aren't following the rules and no surprises, I don't know who's, enforcing on them. But it's another example of, if you're caught in the middle of that and you're a patient getting a bill and you're being threatened to thrown in collections, it's hard to know where to go. Even before the No Surprises Act, I had surgery, and there was an out-of-network anesthesiologist who sent me a bill, which, for the way I was covered and fully insured, was a violation of North Carolina state law.
Mm-hmm.
And, and they sent me a bill, and if I wasn't in the industry and smart enough to quote the general statute back to them, I'm not sure it would have been paid by the carrier, who was the one who was supposed to pay it. But because I could do that, then it got overturned and my bill got paid. Most people don't know how to do that and don't know where to do it. So that's a real problem, the enforcement of the No Surprises Act.
Let me throw you a little bit of a curveball here and kind of merge two issues into one. We got here in this story patients that have managed to go around the denial thing. They've either gotten it appealed by reaching back out to the payer, or however it is that they worked on it in this particular article. At the same time, as you just talked about, there are a lot of people that don't do that because it's very involved when you try to go and appeal these claims. And we know that medical debt is skyrocketing in this country. We have seen, going back to our previous conversation, we have seen Vice President Kamala Harris go after medical debt, and they pride themselves on making that so that it doesn't affect your credit score. They're now talking about eliminating medical debt. How do these two issues play together? Is there an argument to be made to say it almost doesn't matter if your claim's denied anymore because medical debt's not going to matter? What do those two issues, are those two issues related, do you think, in the eyes of both patients, the government, and the insurance carriers?
Well, they are. And I think the thing that I want to see more injected in these discussions is an understanding of, either unintended consequences or the side effects of actions. Everybody understands there's, the Newton's law, for every action is equal and opposite reaction. For every expense, it's somebody else's revenue. Okay. So when we think about medical debt, absolutely, it's something we should address. It's horrible that people who were otherwise paying their bills, et cetera, have something that wasn't their fault, run into a condition, an illness, an accident, whatever, and suddenly they're destitute. That's wrong. Okay. But the easy solution of just saying, well, then don't make them pay it, eliminate or doesn't take into account that somebody else provided that service and they're relying on that revenue to continue to provide that service. If tomorrow, and I know that wouldn't happen, if tomorrow the government said, guess what? ERs are free. They can't bill anybody. When you come in in an ER, they can't bill you. You don't have to pay it. We've gotten rid of this whole medical debt for people who come in an ER. Hooray, patients win. How many rural hospitals would close because they've just been told they got to provide all of these services and not going to get paid for it? How many hospitals, like the Cleveland Clinic, mind you, that have this stellar reputation, provide phenomenal care, would go, well, then I'm just not going to have an ER, and close their emergency rooms? Cleveland Clinic doesn't have an emergency room.
Right.
Why? Because they don't want people to get in there that can't pay. So that's what I mean by you got to think about the unintended consequences. When you're thinking about just writing off medical bad debt or not having it affect your credit rating, how do you temper that with, but somebody else provided that service or that care, and in many cases provided payment, like they bought a drug to give to this patient, and they're not going to get paid for it. What do you do about them? So I want to see a more balanced discussion rather than just looking for the easy button and saying, well, then let's just eliminate it. Right. No, that doesn't fix it. I mean, I know this is a side and I'll get off this in a minute. I was talking to somebody the other day about, the concept of getting rid of student loan debt because these students don't know what they're getting to and blah, blah, blah. And I said, okay, let's say that's a good idea. Do you get rid of it? But what do you do about the next student who's about ready to sign that, that student loan again? Won't the problem just recreate itself unless you deal with the fundamental problem? And I said, because to me, just getting rid of this is like giving an infusion to somebody and not addressing where they're bleeding. It'll just keep going. So Same thing with medical bad debt. If you forget what's out there right now, how do you keep it from accumulating again?
Well, and this goes a little bit back to our previous conversation about Vice President Harris and the election in general, is that there really isn't a discussion right now about healthcare. It has been put on the back burner by both Americans concerned about the grocery store, gas prices, energy prices, et cetera, and been put on the back burner by politicians because they know Americans don't care about it. And it's not very interesting to talk about. If we're being totally honest,
there are sexier things to talk about. There
certainly are, and that's why we are here as the least sexy podcast probably that you're going to listen to today. This article, last thing I want to ask about, this article talks a little bit about EOB reform. Can you tell me a little bit about what EOB reform is and whether or not that's something that can help fix the situation of improper denials and possibly down the road medical debt as well?
Yeah, I mean, I like the idea of EOB reform because if you're not in the healthcare industry, those things are like Greek. First of all, we work in coding that, with numeric codes and everything that nobody else gets. The average person, you say, what's an ICD-10 code? They're like, what? What's a CPT code? What? No, we know it so let's put it in sort of plain language, first of all. Second of all, they're confusing on, wait a minute, do I owe that number? What's that number? That's the write-off, the contractual adjustment. All right, there's denials in here. There's these 2-letter codes. What is this? What's a CO2 denial? Is that, carbon dioxide? No, it's a different. So just putting it in more of layman's terms, easier to read. I'd like for them to be uniform so that you know what they are. And then clear explanations of here's what you owe and why. And then on that EOB, and if you don't agree with this, here's where you go. It would just be much easier, and that would help a lot for all concerned to have common rules, common language, easy to understand. Now, obviously, the industry doesn't want that. They created these codes and these rules and this jargon to make it difficult to understand.
And I will say, as a point of critique for my insurance company, when you email me a notification about an EOB, I would love to know which one you're talking about.
Right.
Because I have no idea when you say that a claim got paid and you don't tell me which claim it is. That would be helpful as well. But I think that's more of a customer service IT issue probably than an EOB reform question.
But think about all the things you can do online with other industries or companies that want to serve you as a customer, okay? Compared to, can you go online easily right now to your insurance company and see where claims are in process? Why can I see that the package that's coming from Amazon just arrived at the Durham distribution center at 8:43?
Right.
But I can't see that a claim is currently being reviewed. Why can I not see in an easy format what's going on? Why can't I see the claims that are currently in process, what they're going to do to my deductible? Why can't I see ahead of time very easily how much more of my deductible I have or what the coach? So we, in so many other areas, we've got this incredible ability for people to do self-service online, but not in healthcare. Well, the insurance companies don't want it. And part of it, we talked about this before, is that the customer is the employer, not the patient. They don't really want the patient.
Right. Well, and I will say also, just as one other critique or suggestion that could be helpful as well, is that when you get a bill from the provider, unless it's a flat copay, it's $20, $40, whatever it might be. If it's a coinsurance or deductible question, it would be good to know what claim it's tied to, so I can go compare the two and not have to try and figure that out myself. Especially when I find discrepancies between the two, it's hard to figure out which one is for which.
Exactly. Yep.
Yeah. All right. Well, this is an interesting article that you're interviewed in, Ron. We'll make sure it's linked in the show notes. This is the New York Magazine article about navigating health insurance claims and beating the system. They label it as a how-to article, which is kind of interesting. We'll also have the link to the MedPage Today article about Vice President Kamala Harris's stance on healthcare issues. And of course, we'll stay on top of that story as that develops. Ron, I appreciate you sitting down with me today to talk about healthcare on the least sexy podcast on Apple Podcasts. That should be our new slogan, probably.
Yeah, exactly.
Thanks, Ron.
Sounds good. Thank you.